Welcome to The Explainer. Today, we are stepping right into the emergency room. We're looking at one of the leading causes of death worldwide. And let me be clear, this isn't just some theoretical review. This is an urgent, high-stakes clinical survival guide for treating acute coronary syndrome or a myocardial infarction. When a patient arrives with a massive thrombus completely blocking their coronary artery, the clock is ticking and myocardial necrosis is actively spreading. Every single second, every pharmacological choice, and every bit of physiological understanding absolutely counts. We're in a literal race against time, and I'm going to guide you through exactly how to win that race step by step.
To really grasp what we're up against, we have to look at the ultimate, terrifying stake here: sudden cardiac death. By definition, this is death occurring within just 1 single hour of the onset of cardiac symptoms. Think about that. A patient is talking to you, grabbing their chest, sweating, signaling they can't breathe as pulmonary edema sets in, and within 60 minutes, without the right intervention, they could be gone. That is the razor-thin margin of error we are operating in today. Okay, let's dive into this. Here is exactly how we're going to navigate our patient's crisis. First, anatomy of a heart attack. Second, the first response, MANAs. Third, managing deadly complications. Fourth, the definitive fix through reperfusion. And fifth, secondary prevention strategies.
Section 1. Anatomy of a heart attack. Identifying the clot.
The very first critical step is figuring out the exact physiological nature of the heart attack. We usually do this through an ECG and by testing for elevated biomarkers, specifically troponin I and T. But here's the crucial point. Once we identify the crisis, we have to understand the nature of the clot itself, because that dictates our entire therapeutic approach. Traditionally, we're taught that a STEMI is a full-thickness infarction and an NSTEMI is partial. But therapeutically, what really matters is the clot's composition. A STEMI features a fibrin-rich clot. This is exactly why we use aggressive fibrinolysis, or clot busters. On the flip side, NSTEMI and unstable angina involve platelet-rich clots. Now, medical science is fundamentally about benefit versus loss, right? So giving heavy-duty clot busters to an NSTEMI patient provides zero benefit, but brings massive bleeding risks. We only use fibrinolysis when we have that fibrin-rich clot in a STEMI.
Moving to Section 2, the first response, MANAs. Initial symptomatic treatment. Once we've identified the crisis, we have to jump into our initial pharmacological intervention. This requires absolute speed and precision to stabilize the patient before we can even think about definitive surgical fixes. We execute this chronologically using the acronym MONA. First, we immediately administer the highest possible antiplatelet dose of aspirin at 325 milligrams, alongside oxygen, since the ischemia is obviously driven by hypoxia. Next, we give sublingual nitroglycerin up to 3 times. This acts as a vasodilator, brilliantly reducing the preload and taking the workload off the heart. Then, morphine is given via IV to reduce chest pain and that sympathetic overactivity that causes that terrifying feeling of impending doom. Finally, we immediately push high-intensity statins, like atorvastatin 80 milligrams or rosuvastatin 40 milligrams. You might wonder, why so early? Well, recent trials prove that pushing high-intensity statins during an acute attack actually stabilizes the plaque and reduces the chance of sudden death by over 40%.
But wait, listen very closely to this because it is a fatal trap. If your ECG shows an inferior wall MI, absolutely do not administer nitrates or beta blockers. These patients already suffer from extreme hypotension and bradycardia because their right ventricle is damaged. If you give nitrates, their blood pressure will literally bottom out. Give beta blockers and their heart rate will crash. Instead, in this highly specific scenario, we actually administer IV fluids. We do this to intentionally stretch the myocardium, leveraging the Frank-Starling law to increase the contractility of that failing right ventricle. This pushes more blood to the left side and keeps the patient alive.
Which brings us to Section 3, managing deadly complications when the crisis escalates.
In that terrifying first hour, an acute attack can spawn sudden, deadly complications. Things like cardiogenic shock, where cardiac output just drops off a cliff. Our pharmacological response needs to be tailored exactly to the failing vital signs. If a patient is in pure cardiogenic shock, we give dopamine, which purely stimulates beta-1 receptors to increase the force of contraction. But if that shock is paired with dangerous hypotension, meaning a systolic pressure under 90, we switch to norepinephrine. This is because norepinephrine stimulates beta-1, but also alpha-1 receptors, creating vital vasoconstriction to bring that blood pressure back up.
Finally, if the shock is causing acute renal failure, which shows up as oliguria, we use dopamine. Dopamine acts on beta-1 but also D1 receptors, actively dilating the kidneys to increase the glomerular filtration rate and restart urine production.
Another massive complication, particularly in anterior MIs, is a left ventricular aneurysm. Think of it like this. The damaged heart muscle can no longer generate force. Because it can't push, the blood just stops moving and pools, and blood stasis triggers clots. If these clots detach, they shoot straight up into the brain, causing a catastrophic embolic stroke. To prevent this, these specific patients require strict, lifelong oral anticoagulants, like warfarin. And if a patient ever suffers a brain hemorrhage from warfarin toxicity, you need to know the exact antidote, prothrombin complex concentrate, or PCC, to instantly deliver ready-made clotting factors.
But the most immediate threat of sudden cardiac death comes from arrhythmias like ventricular fibrillation and pulseless VTAC. The ventricles aren't pumping, they're just quivering. The patient is dying right in front of you. You must use unsynchronized defibrillation, a direct DC shock. Alongside that shock, we administer epinephrine and 300 milligrams of amiodarone. Why? Because these drugs actively increase the heart's responsiveness to the electroshock, giving you the absolute best chance of restarting the engine.
Now, we really need to bust a massive Hollywood medical myth right here and now. Do not shock a flatline. I know in medical TV shows they dramatically grab the paddles and shock a flatline ECG, but in real life, asystole is entirely a non-shockable rhythm. A DC shock will do absolutely nothing.
Now, what's really interesting about this is the actual medical reality of treating asystole. You don't reach for the paddles, you reach for epinephrine. We deliver a full 10 milliliters of 1 to 10,000 dilution epinephrine. The entire syringe must be pushed so it actually reaches the heart during CPR. The biological magic here is that repeated shots of epinephrine can actually convert that unshockable flatline into ventricular fibrillation. You are intentionally inducing VFib because VFib is a shockable rhythm. Once the epinephrine converts to rhythm, then and only then can you grab the paddles and shock the patient.
All right, Section 4, the definitive fix, reperfusion, reopening the coronary artery.
Okay, so we've stabilized them, we've fought off the shock, now we have to actually fix the plumbing. The absolute goal of reperfusion therapy is opening the blocked coronary artery to restore blood supply to the dying tissue. To reopen that artery, we have two main methods, and choosing between them is a strict calculation of risk versus benefit. On one hand, we have thrombolytics, like streptokinase or tenecteplase. These can be given immediately, but they don't just dissolve the clot in the heart. They dissolve clots everywhere, bringing an incredibly high risk of fatal internal bleeding. Because of that danger, they are reserved strictly for STEMI patients where the risk of immediate death outweighs the bleeding risk. On the other hand, we have PCI, or percutaneous coronary intervention, essentially a balloon angioplasty. This is a targeted probe that physically removes the clot. Sure, it takes more time and resources, but it's much safer, highly definitive, and is the treatment of choice for all types of MI, including NSTEMI and unstable angina.
When it comes to reperfusion, time is literally muscle. 30 minutes. That is your absolute first critical deadline. If you're administering thrombolytics, 30 minutes is the maximum allowed door-to-needle time from the very second the patient arrives at the hospital. 90 minutes. This is your next major benchmark. If the patient is having a STEMI and you are going the surgical route, 90 minutes is the strict AHA guideline for first medical contact to balloon time to get that PCI done and the artery open.
And 120 minutes. This is our final countdown clock. For a high-risk NSTEMI, the PCI should be completed within 120 minutes. Additionally, if a STEMI patient arrives at a rural hospital without a cath lab, 120 minutes is the maximum allowed transit time. If you can transfer them to an equipped hospital in under 2 hours, you put them in an ambulance. If the drive is longer than 120 minutes, you abandon the PCI plan and immediately administer thrombolytics as your backup approach.
Section 5. Secondary prevention strategies, keeping the patient alive at home. Our job definitely isn't done when the patient leaves the ER in the cath lab. They go home with a robust cardioprotective drug cocktail to prevent a second, likely fatal attack. First up, we use dual antiplatelet therapy, combining aspirin with a drug like clopidogrel to dramatically reduce sudden mortality. Next, we prescribe ACE inhibitors and beta blockers. These are mandatory cardioprotective drugs that prevent the deadly expansion of the heart infarct over time, while beta blockers also actively prevent arrhythmias. We also heavily manage risk factors, using metformin or insulin for diabetics and enforcing massive lifestyle modifications. That means low sodium diets and high omega-3 fatty acid intake from fish to naturally lower lipids and protect the heart.
And that brings us to the final, permanent reality for anyone surviving acute coronary syndrome. The guidelines now dictate that for these extremely high-risk patients, their target LDL cholesterol must be kept strictly under 55. This requires relentless, lifelong management with high-intensity statins and a complete overhaul of how they live. So I'll leave you with this to ponder. Surviving that dramatic first hour in the ER is a medical miracle for sure. But do you have the discipline to keep your LDL under 55 for the rest of your life? Because that's what it takes to truly survive. Thank you for joining me on this clinical journey today, and I'll see you on the next Explainer.